Hello, and welcome to today's episode of Driving Dr. Kidney with my guest, Dr. Mark Russo of Naples Nephrology, who's going to be talking to us a lot about kidney stuff. I don't know what kind of kidney stuff you want to talk about today. Do you have something you want to talk about with
Well,
us?
yeah, I
Sounds
figured,
something important?
I figured I'd let people just talk about my background, how I got to Naples, how long I've been practicing, things like that. So, I guess I don't know how far back should we go.
I don't know. It's up to you. I mean, we can drive as much as you want.
So, I was born in Brooklyn. I'll take it right back to the beginning.
To the beginning. Okay. Go ahead.
Born in Brooklyn as a kid, moved to Staten Island, then went to high school on Staten Island. I went to an all boys Catholic high school. One of the first things that I remember was walking in there,
Mhm.
looking around, and asking one of the kids, "Hey, where are all the girls?" and and he laughed at me.
Just like I am doing
All
now.
right, and I didn't realize it was an all boys school. Nevertheless, I made it through.
Ah,
I
in
was
one
part,
piece.
correct. I was part of the wrestling team. Enjoyed that sport immensely. In fact, when I went to college, I went to St. Peter's College in Jersey City. Joined the judo team there and did very well in that arena. And later on, then actually started my own wrestling team. They needed a coach at one of the other high schools on Staten Island, St. Joseph by the Sea, and I wound up coaching there. Became the head coach. Started the team, brought it to a winning season. Yeah, that was fun. It was a real big challenge.
Didn't know that.
Yeah. So actually, that's probably where I've gotten most of my skills in terms of starting businesses, making sure the business stays afloat, etc. And it was always a challenge because I was a kid. I was in my 20s, and all the coaches that I was dealing with they were all in their 40s, 50s, 60s. So I found myself having a difficult time communicating with and interacting with those folks. I don't earn my respect, so to speak. So actually, then went to graduate school for a PhD in biochemistry and molecular biology. Joined.
Some people just go to college for humanities.
Right. I went to.
You really went.
Right. Correct. And then what I did was I finished my PhD in biochemistry. Went and joined Dr. Peter Knoll. He's a gentleman that discovered the Philadelphia chromosome. So I worked with him for a bit, and it was through discussions with him that convinced me to go to medical school. What was interesting was at the time, very few first-time grant writers were getting funded, and they were paying medical doctors an average of $10,000 to $15,000 more if they went into research, and that kind of was a slap in the face. You're as a PhD, you're trained to do science, but then again, in medical school, you're not. So here it was, an MD was being paid more than a PhD. It was all to motivate or try to encourage MDs to go into research. Well, so I went to medical school and ended in Brooklyn. Worked under some very big names in the nephrology world.
Like who?
Man O and Hugh Carroll. Fantastic individuals, good leaders. And then I went back to Philadelphia, but this time I went to Thomas Jefferson for my internship and residency, and I wound up actually staying there for my fellowship in nephrology at Thomas Jefferson. Yeah, they worked us hard. Talk about staying up late at night. And that's what my physician had actually recommended to me, that I stay out of New York area. It was because at the time they were putting restrictions on the time that someone can spend overnight or on call. And my physician warned me. He says, "You'll never learn medicine if you're being sent home the next day." He said, work hard. These
Mm.
3 to 5 years, work hard.
Mhm.
He says, and then you'll know medicine, and no one's going to. It's not going to. It's not going to be a problem for you. You'll be a good doctor.
Right. Nobody's going to take it away from
Correct. And then so, and that's why I wound up back in Philadelphia.
you. Mhm.
So then
Mhm.
what did we do? Then I wound up when I chose to stay in nephrology.
Mhm.
It was quite interesting. I since I was trained so well as a scientist,
Mhm.
they had asked me to do the second year first.
Oh.
I would have been so I was actually I had to change my last 3 months, my rotations, my electives
Mhm.
to research. So I was actually doing research, and I was supposed to do the whole the year of research, which is usually your second year. I was
Mhm.
supposed to do that in my first year,
Mhm.
but an individual wound up not coming to the program, and I wound up doing the first year first. So yes, because they created a spot for me. They didn't want to lose me.
They didn't want to lose. Very
I
nice.
was, which was nice. Which
Yeah,
was
very
nice to
nice.
hear
Mm.
that I could have gone to several other programs that I was accepted to. But it was nice staying in the same program. You know the system, you know the individuals, and it was a powerhouse of attending physicians that trained. We had our mix of peritoneal dialysis, hemodialysis, and of course kidney transplant. It was very good. Our advisor, Dr. James Burke, who was actually born at Thomas Jefferson Hospital,
Oh.
he wound up convincing me to stay in the program. Another individual who motivated me and who had a lot of positive influence on me at the time,
Mm.
as well as Dr. Tom Naska. Dr. Tom Naska, you go, keep going straight.
Mhm.
Yeah, it's Tom Naska was originally from Brooklyn, and that's how I hit it off with him
Mm.
when I was interviewing for the program. And so I, of course, ranked Thomas Jefferson as my first choice, as I said. But they worked us. So the next day, so if you worked all day, you didn't go home at 8 o'clock in the morning. In fact, you were considered post call at 5 o'clock the next night, and then you can go home. But again, that's how you learn medicine. That's why these programs today, when I meet with different kids that had trained in a variety of programs, if they didn't work overnight, I was not impressed with their knowledge base. Yes, they can pass the board exam, but that's just memorizing certain facts. And once you do that, you're considered a very well-trained physician. But I remember when I finished medical school, we were trained extremely well in medical school. A lot of hands-on, because at Downstate Medical Center, you had Kings County Hospital right across the street, and many of our rotations were there. And many times we were the doctor. So we were the ones doing the suturing. We were the ones doing, running everything, running codes.
One-stop shop.
Yeah. It was I remember walking in to the emergency room, and the resident told me, he just grabbed my badge and he looks at it and he says, "Okay, Russo, you're running the chest pain clinic today." And he brought me that. What that meant was you walked into a room and there were 6 gurneys, 3 on each side, and all of those individuals were having chest pain rule out MIs. And at the time, we had no blood tests to suggest that, this is an acute MI or this isn't. We only had EKGs, symptoms. There was no emergency catheterizations. that wound up taking place, several years after.
That was a long time ago. Sounds like caveman
times.
Yeah. But
well, not that old.
No, I didn't. No, you look good for it. So how did you get to come to Naples? I mean, how long have you been in Naples, and a little bit about Naples nephrology?
So when after I finished training, I was applying for jobs, and I wound up joining a large practice in New Jersey. Very, very nice. I was the 7th of 9 nephrologists. And I noticed that along the way, it was a large practice. We covered many hospitals. We covered 5 hospitals, maybe 7 or 8 dialysis centers. We had multiple offices. So we're always being shifted around. And I found that that was a little bit too much of a burden for myself. I wasn't able to have a lot of impact on the practice the way I wanted. So I had a partner in that group in New Jersey who felt similar to me. And every time things were getting bad or there were problems, he would say, "That's it, I'm going to Naples." And I'm going to confess something here. I did not know there was a Naples, Florida.
Hey, listen, we didn't either. When somebody told us about Naples, we were like, Naples?
Where is it?
Never heard of it.
Well, you heard of Naples, Italy.
Right. Yes. Good pizza. But I never knew that either. I never knew. So I'm sorry.
You can go that way. There's no bumps that way. So I took a look at the place, and I came down on a vacation. My mom was living here, not in Naples. My mom was living a bit north of Tampa. So her and my brother and myself took a trip here. I had called a hospital. I'd spoken to the chief medical officer at the time. I'd called several nephrologists to see if I was needed. I didn't want to come into an area that was super competitive and start fighting for patients. And it worked out very well. They needed me. In fact, one of the nephrologists that was established here was calling me at least monthly to see if what my plans were. Am I coming here? Am I not coming here? So eventually I made the move. Came here, came down looking for office space, filled out my Medicare application. Thing was a bear, and then really filled out applications for all the insurances at the time. And that was almost 25 years ago. And it turned out that the area was small. Summer times were so desolate here in Naples. You would drive down the road, and many of the lights would be flashing yellow because there was very little traffic. Yeah, like 1-2 o'clock in the afternoon. So your summers, a lot of doctors were nervous because they weren't making a lot of money in the summer, and some restaurants would even close. There were some restaurants would close for the entire summer, or they would close several days per week. We had a lot of good restaurants back at the time. Not that there's not good restaurants here now.
There's a lot of them now.
A lot of them.
A lot of people.
A lot of people. So the population had exploded. So I did actually do a demographic search on the area prior to relocating here. And the growth was, at the time, it had been suggested it was either actually on the East Trail, where you have Collier Regional Hospital, closer to Marco Island, or was the north part of town, North Collier Hospital, part of the NCH healthcare system. And that's where I chose to initiate the practice, because the other nephrologists were more downtown near the main campus. And looking at the numbers, or the potential growth numbers for the area, I chose North Naples. It was more of a friendlier or homier. I got the impression, my wife and I got the impression that they were, that the neighborhoods were a little bit different in terms of, like, the houses weren't all cookie cutter homes. There were, so that's why we enjoy the neighborhood that we currently live in, because it's a non-gated community, pluses and minuses to both. So that's why we chose the non-gated community.
So how long have you been in Naples?
Oh gosh, so we're looking at, it's been 23 years now.
Oh, wow.
Yeah, 23 years.
Probably seen a lot of stuff. A lot of hurricanes.
A lot of hurricanes, yes. I recall my first hurricanes. Oh gosh, I didn't know what to think of. I was just, concentrating on work. And then the staff that was working for me at the time was very nervous, because they'd been living here several years, and I'd say, so what? It's a big storm. Turns out that big storm took the roof off of our first home.
Oh boy! Oh boy! Oh God!
So we had to. I remember we were getting ready to redo that roof, and somebody said, "Oh, you should wait till hurricane season is over." And that individual was quite correct. So I hadn't sold it's something that I was going to invest money in. The insurance company wound up paying a majority of it, minus, of course, our deductible.
So they did. So now you have roof over. Yeah. Naples has become really a nice place to come and to live, and there's a lot of people who come for many months. So whether you're thinking of coming here for the winter months or you're thinking of coming to stay the whole year, please take a look. If you have any kidney issues, please take a look at Dr. Russo and Naples Nephrology, because I think, as you've seen through our little interview, very personable doctor, very nice, easygoing to get along with. You're very welcome. And do you have any last words?
No, my wife and I have loved it here, and we have 2 children. There's so many outdoor activities here. We do have the practice has grown now. We have 3 physicians and 3 physician assistants. We service all of the dialysis facilities in the county, and we have our office, which is quite robust. We're very, very firm believers in preventative medicine. What we do on a daily basis in the office, we feel slows down the progression of kidney disease. We feel it prevents people from going on dialysis sooner than later. If a person does need dialysis, we urge them, and we do send them or refer them for kidney transplant listing at a variety of the transplant centers in Florida. So this way you can get listed. You can actually get listed when your percentage function falls to 20%. Although you don't need dialysis at 20%, you could be listed at 20%. And they could burn up time on the list before they need dialysis or a transplant. And many times they have what's called a preemptive kidney transplant, meaning that the phone will ring and they are not on dialysis and they get the kidney transplant. That's usually that's the most beneficial type of a kidney transplant, is getting it early before you need dialysis. And of course, we usually ask for them to get or talk with or discuss with their family members that they can potentially become a donor. And what some people don't realize is, even if your loved one, family member, friend doesn't match you, they may match someone else that's in need of a kidney transplant, and they have what's called the paired kidney donation program. So there's usually, sometimes it could be 4 individuals, 6 individuals, 12 individuals. I've heard up to where there'll be the donor the donor from let's say from Naples doesn't match that individual's loved one, so that kidney will go maybe we'll go up to Orlando. The Orlando kidney may go match someone in Miami. The Miami kidney then matches someone in Jacksonville. The Jacksonville then matches the Naples one. So it's very, very interesting to have that done. And that's sometimes that's done at one center, sometimes it's done at multiple centers. So, but we refer over to the transplant center, and it is quite extensive work, and it takes a long time. And that's why when we urge people to make that phone call and get on the list, it's not like you're ordering something from the internet. It's not going to come in the next week. This is something that's going to take months to get on that list. They painstakingly go through you with a fine-tooth comb, literally and figuratively. And they want to make sure that you're going to be a very good candidate, and you're going to survive not only the surgery, but that you're going to be alive for more than 5 years after the transplant. They'll talk to you about the medications that you'll be taking. Those medications, since they're immunosuppressive, it unfortunately puts you at increased risk of infections and cancers. And that's why we'll follow you after the transplant, either 3 to 6 months after the transplant. We'll flip-flop visits with the transplant team, wherever it's located. And then we'll take over fully the case after that, usually after the 1 year. And if the person wants to keep going back and forth to the transplant center, we urge that, we encourage it. Always good to have a couple of pairs of eyes on you. to make sure that you're not rejecting. There are, we'll see the individual on a regular basis, do blood work. Sometimes we have to pursue a kidney biopsy, a transplant kidney biopsy, to see if there's any rejection. But that's a rarity. People do extremely well these days. The anti-rejection medications are extremely well tolerated. We've learned to reduce the immunosuppression significantly to find that fine balance between rejection and over immunosuppression, where the patient, again, is at increased risk of infections, cancers, etc. But that's one of the things that we at Naples Nephrology hold on to and really enjoy and try to motivate people. In fact, if the other thing that's part of our practice that we encourage people to do is pursue home dialysis or peritoneal dialysis to avoid having a surgery to put a fistula in their arm for hemodialysis. Correct, not everyone's a candidate for home dialysis, but we'd like to encourage people to consider it, because then if they're just getting prepared for or doing something until they're awaiting their kidney transplant, all it is a catheter similar to an IV tubing, the IV tubing. It's the same thing. We call it a catheter. It's the same thing as tubing. That tubing goes into the abdominal cavity, sits out about, a foot, 12 to 16 inches out of the person's abdomen. And that's where they attach the tubing to allow for peritoneal fluid to go in, sit for several hours, and then remove it. And then sometimes it has to be done overnight. But there's no blood involved. That's why we enjoy, or try to encourage people to do or consider peritoneal dialysis, because of no blood. And then when they're prepared or ready for the transplant, the great thing about it is at the same time during surgery, what they do is they take out that catheter, that tubing, and they place the kidney in the same spot in the abdominal area. It's really the pericolic gutter where the kidney will sit. A lot of people will ask me a question all the time. Hey, are they going to take out my kidneys?
Right.
No, they stay there, and you wait for them to shrink further, and then the new kidney takes over the functionality that your previous kidneys were doing. In fact, it's usually just one kidney, and that's why when someone sadly meets their demise in an auto accident, those two the organs from the deceased person can feed many individuals. You name it, heart. It could be heart, lungs, liver.
There are a lot of people here in Florida that are organ donors. I, for example, myself am one too, and I think that's a great thing to do. Even after death, you can still have gifts to give to other living people. That's very nice.
It is, yeah. That's why I urge everyone, to have that donor card. Other than religious beliefs, when you're no longer with us, you don't need those organs, and so it's always a good idea to be a donor. And nowadays there are more. It's becoming more acceptable through many religions, and so years ago there were some religions that would give us a difficult time, or that wouldn't have those beliefs. But now, again, it's becoming more accepted, and so we're seeing individuals that previously were not doing it or accepting it are doing it now.
So, do you want to would you like to tell us a little bit about hemodialysis opposed to peritoneal? Because you mentioned peritoneal, and I don't know if our watchers maybe understand that difference.
Okay, so the difference is, well, the job of dialysis itself is just to take your blood out, clean it, and give it back to you. Or even a higher level understanding of this is dialysis is to remove toxins from the body, do the job of the kidneys, what the kidneys were supposed to be doing. And what's the job of the kidneys? Not only removing toxins, balancing the pH, balancing electrolytes, and of course removing fluid. So we call it the person's when you get up in the morning and you go to the restroom and evacuate yourself, you're at what we call your dry weight, as we call it your dry weight now.
So that's the best time to go and measure yourself.
Measure yourself in the morning,
because
right?
you have less weight.
Less weight on board, right? So now you're at your dry weight. Well, your kidneys are really what finds that dry weight. So when you're on dialysis, it's your kidney usually does it for you, but on dialysis we have to do it for you, meaning the nurses and the doctors and the staff at the dialysis centers have to come up with that dry weight. And it's a balance between what you feel like, what your blood pressure is, and theoretically, and it's really, I underscore the term theoretically, anyone who's on dialysis, whether it be peritoneal dialysis or hemodialysis, they should not be on any blood pressure medicines if dialysis is going well. But it's rarely achieved. It's rarely achieved because there are more things that go into the unfortunate pathophysiology of dialysis or end-stage kidney disease.
So what does hemodialysis and peritoneal dialysis look like to the patient? What can they expect?
So hemodialysis is when we take the blood out, clean it, and give it back to you. So hemodialysis, you usually have a fistula in the arm, or it's an AV graft, and that's a foreign piece of material. The goal is to attach the artery and the vein in the person's arm. And the reason for that is if you were to try to access a person's veins on a regular basis, 3, 4, 5 times a week, those veins would become necrotic and thick and rock-like after a while, so they would not be usable. It would look like the person has veins, but they're all filled with clot. So many, many years ago, it was determined that, wow, if we attach the artery to the vein, that vein now becomes thicker and thicker, or more lifelike, similar to the artery, and it's more difficult to lose the functionality of that vessel. It will stay patent much, much longer. And that's called arteriolization of the vein, where it becomes very, very thick. So that's an AV fistula, when they attach the artery directly to the vein. And again, that will allow for continued access, for the needles to put into that fistula over and over and over again, without damaging the blood vessel. Now, sometimes people's vessels are way too small, and they cannot form or create a fistula, meaning hooking the artery directly to the vein. And the surgeon will determine if you're one of those individuals that actually has to have a foreign piece of material or a graft, so this way that piece of material gets accessed over and over and over again. But it is still attaching the artery to the vein. It's attaching the artery to the vein. So that's the access for hemodialysis or blood dialysis, where you would go to a center 3 days a week, or you would perform that at home after extensive training in the dialysis facility. You get that training, and you would have a loved one that helps pursue it. In fact, if you look at historically, back in the 60s, before Medicare took over or agreed to pay for dialysis, back in the 60s, there were what we used to call the death camps, or the individuals that would meet to decide whether or not that person was fit for dialysis. It was like the death councils, if you will. And that sometimes it consisted of a physician, nurse, a priest in the area. Sometimes there would be community folks that were involved in the community, and they would all be helping make the decision whether or not that person was fit for dialysis. And again, remember, this was prior to Medicare saying that they're going to pay for it. So many insurances, this therapy was relatively new. Few insurances would even cover it. So you couldn't, things that we do differently today than the 1960s, if you were a diabetic, you were not considered a candidate for dialysis because your life expectancy was only a short period of time. We didn't have all the wonderful medications that we have today to keep a person alive. So those people were sort of shunned away. If you had to have a job, if you didn't have a job, they could just say, nope, he's not contributing to society,
Oh, wow.
so no dialysis.
Oh, wow.
Certain ages, if you were elderly, what was considered elderly in the 1960s, well, probably in the 60s and if you were in your 60s, 70s, you would not be considered. There was the makeup or the machinery for dialysis was, of course, it was in its growing stages or birth stages, if you will. So it took a lot of water, it took a lot of material for the individual at home to be doing dialysis. There were no dialysis centers. Everything was done at home. So that's how dialysis was born. It was born in the home. It was not until Medicare agreed to pay for this in the early 1970s, the act came down reading that if a person was a United States citizen, had worked a certain number of quarters or years in the system and paid into the Medicare system, regardless of age, they would now be qualified to receive Medicare benefits to cover dialysis. Now, at the time, the nephrologists believed that dialysis was only going to be a bridge to kidney transplant, and because transplantation was also coming, it was rather new at the time as well, and they thought that, and we didn't know anything about the medications. There was all these newer transplant medications at the time too. So the nephrologist had said, look, this is only going to be for a short while, dialysis. And at the time, we only had a few thousand people on dialysis. So it was an easy decision for Medicare to make when in terms of, well, if it's short-lived, it's not going to be needed for a while. Yeah, let's agree to pay for it. Well, many things have happened since then. If we look at the dialysis population today, it's in the hundreds of thousands, close to 1 million people on dialysis in the United States. So look at it. So if you're in office in the 1960s and you want to pay for something, oh, okay, yeah, this doesn't seem like it's going to be an expensive program when there's several thousand people and now there's almost 1 million. So there's reasons why dialysis is being targeted for cuts, avoidance, et cetera. And that's why it's imperative to do what our practice does on a regular basis in terms of trying to prevent the person from going on dialysis, managing aggressively their blood pressure, trying to squeeze down the amount of protein that they have in the urine, painstakingly manage their blood pressure, squeezing it down to a very respectable numbers that they can tolerate without having sensations or feelings of falling over, making the dietary changes or lifestyle changes, we like to say. And again, it comes not only with diet, but it comes with exercise. That's why Naples is a great place to live. Why? Because there's not only a lot of intelligent people here, or educated people or folks, they're health conscious. And that's why you'll see when you're outside, you'll see people riding their bicycles more or running or exercising. So yes, we do have, although it is a great place or a fun place to live, we like to call this the spring break for the middle-aged, if you will. But, they have fun, work hard, play hard. But that's the other problem that we're having, that Naples is facing. And we have so many people that are moving here as retirees, and very few people that want to work or have worked. And so what happens? We're in need of support services, and physicians are a support service. We're inundated with work.
I guess that's always a good thing that you have. But and it's also, in a way, it's a good thing because you're helping people live longer, survive, thrive, and enjoy their life down here in Naples, where there's palm trees and sunshine. Very nice.
Yeah, it is. It's definitely been a fun 20-some years in practice here, and helping individuals. You do make relationships. You do get relationships with folks. Wound up becoming friendly with them, not only just in terms of them coming in and visiting with us during that visit. Sometimes we get we'll get invited out to parties. We were just invited to a 90th birthday party. I've through the years I've gone to my one of my favorite pastimes is baseball. I do enjoy baseball games, and so we have the local spring training games here that I've gone with patients to some of these ball games, and we make trips over to Miami to watch the Marlins play when other teams come in. I used to had a patient that was a big Philadelphia Phillies fan, and I recall after the year after the Phillies won the World Series in was it 2007 or 8, I took him the following year to a Miami Marlins game. We had nice seats, dugout seats, congratulating him and his Phillies winning the World Series. So yeah, you do make those relationships, and these individuals, like, as I said, well educated, well rounded. I mean, we take care of people that were, with high in the armed forces, retired generals, retired judges, attorneys, doctors, CEOs of major companies that we've taken care of through the years to avoid any HIPAA violation. With this being used against me, I won't mention any companies either.
No, our names, of course.
But
a lot of people.
Yeah, but we do, and our practice does take care of a significant amount of individuals. So, and that's another issue that we're facing. Nephrology does not get reimbursed as lucrative. It's not as lucrative a field as, let's say, cardiology or gastroenterology. And there are some hospitalists who actually have a better lifestyle or make more money in reimbursement. So it's been very, very difficult to convince or encourage physicians to come into this field. We haven't filled a class of nephrologists in, it's been well over 20 years that it hasn't been filled. And it's sort of balanced out, or it's sort of hit a plateau, and we're hoping there's a significant turnaround, but it's the only way to motivate people is to pay them more money. And it's difficult to pass on the cost to the consumer, because your consumer is who? We like to think, as physicians, we like to think the patient is the consumer.
Right.
But sadly, the patient is not the consumer. The consumer is the insurance industry. And I can't call the insurance company. I've tried. Hello, Mr. Medicare, Mrs. Medicare. I need a raise. What is that typically met with? Well,
it's always met with, yeah.
You need an act of Congress to give us a raise.
Well, not just that. It's in general even. It's give me a raise. No.
No, sadly, no. So that's why you hear a lot of things about the concierge practices that are out there that are pushing the insurance companies away, the doctors and the patients both pushing the insurance companies away, saying, no, you're not the customer anymore. I want the patient to be the customer, and the patient wants to be the consumer. He or she wants to have access to that physician. They don't want to have to be told that there are limited choices in what they're doing for their healthcare. So, so that's.
Well, the main thing is a lot of patients, luckily, are getting life-saving help with this. So it's a very nice thing that you guys are doing, and people can enjoy this lovely weather without a lot of problems. Very nice. Well, thank you for listening, everyone. I hope you enjoyed this interview that we had with Dr. Mark Russo today, and hope that you will join us again soon and be able to listen to the different other things that we'll be talking about with Dr. Russo again, and possibly with other of his colleagues. So thank you, Dr. Russo.
Thank you
very much.
Pleasure being here today and driving with you. Yes. Rather safe. You got me to my destination quite safely. I appreciate it.
Thank you so very much.
Is this an Uber ride?